on your laptop?
I think there's some problem in this camera today. Anyway, I'll stop the video. I'll just be on this thing. Okay.
We can start the webinar and then go live, I think.
Yeah, sure.
So as per your signal, yeah. So can we start now, sir?
Yes, please go
we
ahead.
can go now.
Okay, Ronak.
Sure, sir. I'll just allow the attendees to join.
Okay.
Hello.
Maybe after a minute or two, we can start. Then Sanjay boss, I think we can start.
Okay, we should start now.
Okay.
So it is already at 5. So good evening, everyone, and thanks to everyone who has joined here just in this debate. And my special thanks to, first of all, our team expert panelists, Dr. Ravi Shankar sir and Devashish sir, and both his speakers, Bimal and Ravi Unial. And as Dr. Rathod mentioned, we have started controversy to consensus series. And in this debate on headache, we are debating for the first time. And we have chosen topic NDPH. Definitely it is a debatable topic, but I don't know how many would join here. So maybe an awareness for the NDPH among many neurophysicians. But is there really any controversy in this NDPH? So if you go to ICSD 3 criteria, it has mentioned just continuous headache for 3 months with a distinct and clearly remembered onset. Criteria or definition seems to be very simple and straightforward. So what is the controversy? Controversy is in itself in a criteria or definition. clearly distinct and clearly remembered onset. It means there should be suddenness type. There should be acute onset. And clearly remembered onset means there will be moderate to severe headaches. So there are two red flags in criteria: acute onset and moderately to severe headaches. So in criteria itself, it suggests there is something in secondary headache. Many other things are there. ICSD almost silenced regarding the phenotype, but phenotype may be both migrainous and tension type headache. So there are two variants considered: chronic migraine type and chronic tension type headache. But few people now consider they are actually not the chronic variant of NDPH, they are actually the chronic migraine of NDPH types. So there are several secondary headache which may mimic NDPH, and many even primary headache may mimic NDPH. So there is some controversy, and many people now consider, just recently in Cephalgia, one article was published, times to retire for NDPH. So considering is a heterogeneous disorder, we consider it as a to debate on this topic, whether it is really a primary or thus heterogeneous with a different etiology. So initially we scheduled this program to first on the NDPH as a primary headache disorder, and later on in the secondary headache disorder. But now we have rescheduled it, and first lecture will be on the NDPH as a secondary headache, and Dr. Ravi Unial will be speaking on that. And after that, Dr. Vimal Pariwal will be speaking on the will debate on the as a primary headaches. So before we start, I will ask a few words to say Dr. Ravi Shankar sir and our expert panel, Dr. Devasis sir. Dr. Ravi Shankar sir, please.
Yeah. Good evening, everybody. And this is a well-chosen topic across the headache world in most of the meetings. Wherever you have a debate, whether it's CONI or whether it's an international meeting, this is usually a topic which is given to some of the good speakers, whether NDPH is primary or whether it's secondary headache. I, for one, would not like to give away my way of thinking right at the beginning, because there are two speakers who are going to put out their thoughts. But this entity is usually very easy to diagnose. And I can only say that in order to sort of set the ball rolling, that it is an easily recognizable disorder. And when you can recognize a zebra, you don't need to have a debate to argue whether it's a horse or a mule. So you have to learn to recognize the zebra. And just as we have pattern recognition, we don't say primary migraine and secondary migraine. We use the word migrainous. We don't say primary cluster headache and secondary cluster headache. We always do an MRI. So the controversy should start by letting everybody in the audience know that we are talking about new daily persistent headache. We are not debating new onset headache. It's the premise, it's a basic premise of every neurology resident, that every new onset headache must be investigated to the fullest. So let the two participants understand.
There is some error at Dr. Ravi Shankar's side.
Okay.
I think we have lost connection with Dr. Ravi Shankar.
Okay. Sir, now Devasis sir, would you like to say a few words before starting the program?
Yes. So good evening, everybody. I think it's a good, for the theoretical sake, it is a good topic to debate. But personally, I think that it's just a descriptive term, which of course defines headache syndrome, and which happens, reasonably acutely, and which is remembered from the beginning, and then it becomes persistent. So these are the three characteristics. Now, whether that qualifies as a morphological diagnosis, because after all, most of the primary headaches are defined by certain operational criteria and there are no biomarkers. So here also we don't have any particular biomarker for that. And when we talk about distinguishing between primary and secondary headaches, we know that all of us have seen patients who have the phenotypes of primary headaches, starting from migraine, tax, and other groups who can have a secondary cause lurking underneath. So therefore, I think it all depends on the perspective, how you actually see these cases, and what will be your approach. So I think these two, debaters will focus on that, and they will be able to tell us more about that, what they think, and then we can take an opinion poll from the participants, rest of the delegates, and go ahead. Thank you.
Okay, sir. Thank you, sir. So we will go for now poll as a tradition. First, we will go for the poll. So first question.
Sure,
Please.
sir. I'll just launch the.
Have you diagnosed a case of NDPH in last 1 year? Just a yes or no.
I think we can show the results now.
Sure, sir.
Yeah. 25 participants and 14 have seen the cases and 11 have not seen. Just equal 56% and 44%. So still some people have not seen. So, okay. Now we will go for the real question regarding this topic. So next question.
Sure, sir. Just one second.
Okay. So what are your thoughts on New Delhi persistent headache? A primary headache disorder in itself, a syndrome with different etiology, or I have never heard of this?
Request all the participants to please vote. So that will maximize the input. We will be able to judge what is as it really changes after the debate. I think we can show the results.
Oh. So after the result, 42% is considering is a primary headache and 50% with a different etiology, and 8% have not heard of this. So now we will debate on this issue and we will see whether there is change in this ratio or not. So I will invite first Dr. Ravi Unial for debating NDPH as a secondary headache, and after that Dr. Paliwal. So Dr. Ravi Unial, now you just go ahead. So you can share the slide.
Thank you, Dr. Sanjay sir. Is my PPT visible right now? Sanjay sir?
No, it is not visible. Did you share? Please, technical team, just look in the matter.
Sir, what issues are you facing? Please click on the green button at the bottom of your screen that is called a share screen.
Yeah, I have done that.
Still you haven't clicked on it, and once you see that there is a checkbox at the bottom, please share your whole screen and then open the PPT.
Ravi, it is possible that too
Sir,
many.
it's showing open system. I don't know.
Can you see share screen button on this Zoom screen?
Yes, sir, I have clicked that, and it's showing
Okay.
desktop 1, but there is some exclamation mark there.
There may be multiple windows open on your desktop or something like that. So just open your only the PowerPoint and close other windows. That may be the situation, what I can see.
Okay, sir. So right now I have closed all of them, and it's again saying that open system preferences.
Sir, which laptop are you using?
It is MacBook, sir.
Just 1 second. And is there any specific version of MacBook you're using?
Sir, I bought this in I think 3 years back. So at the time it was the latest version. Is there any issue with the accessibility?
Is it possible that you share this, your PPT with support staff, they launch it here? You just say that change slide and they'll change the slide.
What you
In
can
the
do.
Zoom setting, it should say allow permission to see everything. Then it will allow to share.
Sir, it's
Otherwise, I think what we can do is Dr. Vimal can start, and in the meantime, you can share your email to Sanjay Bhai or to the support staff, and they can play it from their computer.
Ronak, you give your email ID in chat box, so sir will share on that.
Okay,
Yeah, that will
meanwhile,
be
I
a
think
better.
Vimal can initially start. Okay, so that will not be a matter.
Same
I
time.
think we can initially debate about the primary headache disorder, and then Ravi can take over second. Okay, Ravi, you share your PowerPoint to the support team so that it can be shared through their system, and then you can speak once. I think Vimal, you can please start then.
sure, sir, sure.
Is it visible?
Yeah, it is visible.
Okay. Good evening to all of you. I'm actually really very happy to present this debate in front of legends of headache. And Dr. Ravi Shankar, Dr. Devashish, and Dr. Sanjay have actually already summarized this topic very, very well. So my job is not that difficult now. Now, the Ravi actually would have proposed that that NDPH is probably a syndrome or a secondary headache. And so I had to rebut that it is probably, I'll just hypothesize that NDPH is a syndrome. And the reason for hypothesizing it is it has got multiple triggers. There is a wide clinical heterogeneity regarding this headache. There are high psychiatric comorbidities, which itself is more represented in this headache type. And there is no unifying pathophysiology in NDPH. And I also hypothesize that it could also be a secondary headache because of, as Dr. Sanjay has initially said, that there is acute onset of headache which is of moderate to severe intensity, so much so that patient tends to remember the onset of headache. Since the onset, the headache is unremitting, continuous, and lasts for months together. And both of them are actually red flags for primary headache. And the next very important part as a red flag is poorly responsive to treatment. So let us see how we are able to either prove or disprove these hypotheses. Now, this is a primary headache model of New Delhi persistent headache. What happens is that there are a large number of triggers which are known to incite this New Delhi persistent headache. The important one being infectious triggers, cervicogenic triggers, Valsalva event. A single Valsalva event may precipitate the headache. The infectious triggers are like upper respiratory tract infection, mostly have been viral ones. Cervicogenic triggers is extreme movement of neck, like as in case of intubation. Once the headache starts become continuous from the onset, it's unremitting and lasts more than 3 months. There is wide clinical heterogeneity in the form that both headache types, like migrainous characters as well as non-migrainous, that is characterless headache or tension type headache features, are both included into the entity of New Delhi persistent headache. And what happens to headache is either it spontaneously resolve or remit in a small proportion of patients, and in majority it remains unremitting and it almost drug resistant. Now the issue is that there is no unified pathophysiology, underlying pathophysiology or mechanism of this headache, which is known to us. So this is a primary headache model, and at present time, the ICHD 3 has placed this headache into other primary headache category. So at present time, ICHD recognizes this headache as a primary headache. Now, if we see migraine and compare migraine with this New Delhi persistent headache, this is a primary headache model of migraine. So there are so many similarities between migraine and New Delhi persistent headache. So there are a large number of triggers. Now the number of triggers that are known with migraine is a huge list, and there is no comparison with NDPH. There can be sun exposure, sleep deprivation, fasting, stress, bright light, sounds, multiple type of food triggers, and multiple other triggers, long list. So these triggers are known to incite headache, which is initially an episodic migraine. This episodic migraine, when it gradually increases in frequency, evolves into chronic migraine. Now there is a wide heterogeneity of episodic migraine, which is well known, and each has been separately described in International Classification of Headache Disorders. These can be migraine with aura, migraine without aura, typical aura with headache, typical aura without headache, headache, migraine with brainstem aura, hemiplegic migraine, retinal migraine. And once it transforms into chronic migraine, again the heterogeneity persists, because the ICHD-3 says that since the headache of chronic migraine varies from day to day, to include each episode, the migraine as well as tension type headache also have to be included into the criteria. So again, like NDPH, chronic migraine includes both migrainous headaches as well as tension type headaches. What happens to chronic migraine? It may resolve and remit into episodic migraine with or without treatment, or it may be unremitting and drug refractory, which we see at tertiary care centers. Now, what is the difference between this primary headache model of NDPH and primary headache model of migraine is the pathophysiology, because in case of migraine, there is a unifying pathophysiology which unites all these type of clinically heterogeneous headaches. Now, the Ravi would have proposed something like this, because the game of saying NDPH as a syndromic headache starts in late 90s, when there was one paper which said that this could be a syndrome. And the reason for saying syndrome is that people think that if there is an infectious trigger to start headache, it is the pathophysiology related to infectious triggers which actually results into headache, which is continuous from the day one and it's unremitting. Same is true for cervicogenic trigger, same is true for single Valsalva event trigger, and same is for other triggers. So it means that this is a bundle, like it is a constellation of different headaches, which are unified by the duration and unremitting character right from the first day. Pathophysiological link is the link to the trigger, and the clinical heterogeneity persists, the spontaneous remitting or unremitting character persists. So that is why people say that it could be a NDPH bundle or a syndromic headache. Now, my issue is that why not to call it as a secondary headache related to infectious trigger or cervicogenic trigger or a single Valsalva trigger, but it's not a secondary headache then. No, the issue is that we can call it as headache attributable to infections or headache attributable to forced cervical movement or headache attributable to psychiatric condition. But we cannot call it like this because the ICHD has already committed to the criteria of secondary headache. For any secondary cause, the headache should be temporally related to the onset of that cause. Second, headache severity should correlate with the severity of that trigger. And then headache should also subside when the trigger subsides. So first criteria is fulfilled. The other two criteria are not fulfilled. So that is why people are not saying NDPH as a secondary headache. They are more conveniently saying that the New Delhi persistent headache is a syndrome and not a secondary headache. Now, by these diagrams, I think I have been clearly able to tell that the hypothesis which I proposed initially doesn't stand. And there are several points which favor that NDPH could be a primary headache. The causes I want to remunerate once again, that there is no underlying structural or non-structural cause till date. There is no standalone mechanism of New Delhi persistent headache. So different etiologies proposes different mechanisms, and those mechanisms have also not stood the test of time. So that is why people are saying that this is a syndrome. The triggers related mechanism do not explain the persistence of headache after the trigger has subsided. That is why we cannot also call it as a secondary headache. So my concern is that once we say that this is a primary headache with so much of heterogeneity, so many of triggers, why can't we call this as a primary headache also? So the present situation is this, that NDPH was actually introduced as a primary headache. But since the primary headache category was so saturated, we have considered it as other primary headache. As the knowledge increased, we started thinking that could this be a syndrome? With recent paper like ours, we are saying that could this be a secondary headache? So my issue is why there is so much of haste in naming New Delhi persistent. Let it be like this, let it be the way it is. Because migraine, we have been able to keep it in primary headache category because the entity has evolved over decades. It is more centuries old entity. The research has been for decades together, and we have a clear pathophysiology. The unifying pathophysiology, that is why I'm saying that it is very important to understand whether the diagnosis is primary or secondary. In NDPH, it is hardly 4 decades old. We don't know the pathophysiology, and that is the only reason that we are debating this topic. Once we have a clear pathophysiology, probably we'll be better off in understanding whether it's a primary headache or a secondary headache. Thank you so much.
So thank you, Bimal, for your excellent presentation. Just there are so many lectures, so many studies suggesting as a secondary NDPH, but you defended it very nicely.
Thank you, sir.
So it was really wonderful to hear you. So just I would like to say just again we will go for a poll whether your lecture just modified some person or not.
No, I think poll we will take after both the debates.
Okay. Okay. So then we will move for the second lecture. So is it ready?
Ravi?
Hello.
The support team, did you get the support team now? Did you get the slides?
Yes, sir. I do have his slides. I was just speaking to him with the doctor, sir, on the phone, and I was trying to get this issue resolved. But I guess it is not happening, so I'll share the screen for him.
I'll share the screen.
Yeah. Just allow me 1 second, sir.
Yeah.
Hello, is my screen visible?
Yeah, it is visible.
All right, I'll just put it into PPT mode. Just give me 1 second.
Slideshow mode.
Yeah, Ravi, you can please go ahead.
Yeah. Thank you. Thank you, sir. Good evening, everybody. This is a huge privilege for me to present my point of view in front of the legends of headache medicine, Dr. Ravi Shankar sir and Dr. Devashish sir and others. Sir, it's an honor for me. Today's topic is whether NDPH is a primary disorder or a syndrome. And I'll be putting my arguments to prove that NDPH is actually a syndrome and not a disorder. Sir, am I audible?
Yeah, you are audible.
Yeah. But before that, please next slide. But before that, I just want to give an overview what the NDPH is. NDPH or New Delhi Persistent Headache was first described by Dr. Walter J. Vanast in 1986. And when he described this condition as a benign syndrome because most of his patients actually recovered. But after that, all over the world, many clinicians and researchers found this entity as one of the most treatment refractory. This condition is characterized by acute onset of daily, unremitting, continuous headaches for 3 or more months. The most interesting and most elusive phenomena of this headache, this type of headache, is remembrance of onset. All the patients of NDPH are able to recall the onset of their headache. They are able to remember when it all started. And the other interesting feature of this type of headache is triggers or antecedent events. Not all, but majority of the patients actually report some kind of antecedent events or triggers which they think is actually cause of their pain. Next slide, please. So my notion is that NDPH is actually a syndrome. Why am I saying that? I have certain reasons. The first thing is the clinical presentation of NDPH is too varied to be called a disease. The other thing is even after the 36 years of its inception, still there is no definite unifying pathophysiology which is acceptable to all. And similarly, there is no specific treatment. Next slide, please. So the first point, the clinical presentation is too varied. If we see, the patients of NDPH can present with a wide range of clinical manifestations. Actually, they can present with the both extremes of the spectrum. On the one hand, they can present as benign self-resolving conditions, and on the other hand, they can be the most refractory headaches. On the one hand, they can present as headaches which are just like tension type headache without any features, and on the other hand, they can be full-blown migraine. They can present with triggers or they can present without triggers. So in a way, the clinical presentation of NDPH is too heterogeneous to be called a disease. Next, please. If we look at the definition of primary headache disorders, this is given by International Headache Society. This says that primary headaches are disorders by themselves and they are caused by independent pathomechanisms and not by other disorders. So essentially, primary headache disorders are defined by their independent and specific pathophysiology. Next, please. And if we look at the pathophysiologies of NDPH, actually there is none. There is, till now, there is no consensus on any pathophysiology which can explain the genesis of NDPH in all the patients. However, there are theories. There are theories by certain researchers which were proposed by them at certain times. They can explain the genesis of these headaches in certain group of patients, in certain subset of patients, but not in all NDPH patients. The first one is viral or infective theory. Essentially, this came into existence because many of the NDPH patients report flu-like illness as a trigger before the onset of their headaches. The biggest proponent for this theory was Dr. Vanast himself, and he actually demonstrated active Epstein-Barr virus infection in his NDPH patients. However, in later studies, it could not be confirmed. The next one is cervical spine hypermobility. It was proposed by Dr. Rosen, and he actually described certain patients of NDPH in which he demonstrated the cervical spine hypermobility. Apart from this, he also described some patients of NDPH who developed NDPH after the surgical procedure, which involved intubation. So he proposed that the cervical cord is the genesis of this kind of headache, and cervical manipulation can trigger this headache. The other one is a psychiatric origin. This essentially came into existence because many of the patients report stressful life event as the trigger for their NDPH. And apart from this, many studies have demonstrated many psychiatric comorbidities, including anxiety, depression, and somatization in their patients. So this is one of the factor. Next slide, please. If we look at the somatization is characterized by persistent and disproportionate thoughts about their symptoms. We did a study to look for the somatization behavior or somatization tendency in these patients. What we did, we inquired our patients about their past somatic symptoms. And if the somatic symptom was remembered, if we were able to recall the onset of that symptom and the symptom persisted for more than 3 months, we termed this as a NDPH-like somatic symptom. And to our amazement, around 70% of NDPH patients were able to recall at least one NDPH-like somatic symptom. And at the same time, none of the chronic migraine or tension type headache could recall such kind of symptom. So it appears that the somatization behavior or somatization tendency, which actually makes them think about their symptom, their headache persistently, may be playing some role in remembrance of onset of headache and persistence of headache in these patients. Next slide. So if we look at the all theories which have tried to explain this headache, they are too divergent, and it's very unlikely that they are operative in all the patients. These theories may not be operative in all the patients. They may not explain the genesis of headache in all NDPH patients, but they may explain the genesis of headache in some of the patients. And if it's true, then the different subset of patients ideally should belong to different disorders, as we know that primary disorders are defined by their specific pathophysiology. And if different pathophysiologies are involved, then we are probably talking about different disorders. Next, please. Next slide, please. Similarly, there is no specific treatment. Till now, there is not a single drug which we can say that it is specific to NDPH. So how we manage these patients? If patient comes with tension type headache, we treat him like tension type headache. If patient comes with migrainous features, we treat him like migraine. If patient develops this kind of headache after a viral illness, we treat him with steroids. If patient develops NDPH in the background of psychiatric conditions, we treat the psychiatric conditions. So in a way, we are actually treating so many disorders in the name of NDPH. So it appears that the NDPH is a syndrome which includes all these disorders which have different pathophysiologies and different lines of treatment. Next slide, please. My other notion is that NDPH is a secondary headache. Why I'm saying that? The two important features of NDPH, the one is acute or abrupt onset, and the other is unremitting nature since onset. Both of these features are considered as red flags for secondary headaches. So it's very natural to say that it's a secondary headache. Next, please. And if we look at the theories which have tried to explain the genesis of headache, they all point towards some secondary headaches. If we see the viral or infective hypothesis, this actually points towards the headache attributed to systemic infection. The cervical spine hypermobility indicates cervicogenic headache. The psychiatric origin is actually used to explain the headache attributed to psychiatric disorders. So in a way, we are trying to explain the pathophysiology of NDPH by the theories which are meant to understand or explain the secondary headache pathophysiologies. So if these pathophysiologies are involved somehow in genesis of NDPH, then this should be a secondary headache. Next, please. In the last, I want to say that in last 36 years, with all the research, we have not arrived at any acceptable pathophysiology for NDPH. We have not arrived at any specific treatment for NDPH. Are we going in wrong direction? Probably if we make the NDPH a syndrome of clearly remembered onset and persistent headache, and we put all these different phenotypes under this umbrella term as different disorders based on their presumed pathophysiology, maybe in the future, we may be able to explain this phenomena of NDPH in a better way. Thank you very much for patient listening.
Thank you, Ravi Unyal, for your presentation. And now after this both lectures, now we will go for the poll, and after that poll we will debate on that issue. So can we go for poll now? Support staff, please.
Sure, sir. Just 1 second.
So please poll for these questions.
It's the same question which we have done earlier. So request everybody to vote so that we can know the opinion of all the delegates. You can show the results.
So now after this debate, percentage for as a secondary went a little bit higher. Initially it was 45% and 55%, it is now 65%. So people thinking of it as a syndrome more likely. So after this, I will ask Dr. Ravi Shankar sir, so your take on this debate on in this topic, sir. And before that, I will ask sir just one question: how confident are you making in diagnosis of NDPH? Do you still feel after making a diagnosis of NDPH that still we are missing something in these patients?
Yeah. Now, I feel that we have 150, close to 150 people attending this. We need to be on the same page, all of us. So let me take a little time to put things in perspective.
Yes, sir.
Now, having seen more than 100 patients of NDPH, it is not at all difficult to recognize the pattern. Now, this entire debate is around the word persistent. Every patient who presents with new daily persistent headache, NDPH, you recognize the pattern. You do all the investigations A to Z. You have a set battery of tests, which includes MRI with contrast, MRA, MRV, and CSF. And you conclusively rule out a secondary. And then it falls back as being a primary headache where you still do not know the pathophysiology and the causation. All the factors mentioned are associations. They are not causations proven. Whether it's cervical spine mobility or infection, these are associations, not causation as of today. So now, that being so, there are many entities where you still do not have clarity on what is going on, but you definitely know what you're dealing with, and all the way you treat with anti-migraine drugs, you treat it with gone blocks, you treat with Botox, you treat with steroids, but you still want to call it a secondary headache. The entire playing field was vitiated because one of the leading experts in the world decided to publish a paper in 2011 where he divided NDPH into primary and secondary. Before that, for 25 years, the same experts put it into two classifications, all under primary. Now, this publication in 2011 by a leading expert, it doesn't mean if what Sunil Gavaskar and Sachin Tendulkar say about cricket, they are not always correct. So here you do a pattern recognition. You don't use the word secondary, you call it NDPH like heterogeneous clinical presentation. You do the full battery of tests. If you are still negative on all the battery, it comes back to the saying that here is a pattern recognized primary headache disorder where today you don't know the pathophysiology. You have a number of associations. You don't have causations. You treat like a primary headache, but you still want to call it a secondary headache. Where does a tumor persist? Where does a subdural, where does a subarachnoid, where does an RCBS have persistent headache? You, Sanjay, Debashish, me, we have treated a refractory difficult NDPH. We know how many things we have to try. All of them are from the migraine field. But you still want to use the word secondary. So I would say, call it NDPH and NDPH-like, as you use migraine and migrainous. Every cluster headache, you do an MRI. Like that, here every NDPH, you will investigate to the fullest. Why to the fullest? Because it is new onset. Otherwise, what will happen is the attendees who are coming here, who are not initiated into headache the same way we are doing only headache practice, they will go away with the wrong thought that there is something called secondary NDPH, there's something called primary NDPH. No, it is a clinical pattern where you rule out secondary underlying conditions to the fullest and then treat like a primary headache. So this is my way of thinking. Correct me, and Debashish is there, Sanjay is there, who have seen a lot of patients. So we'll allow the speakers also to interview.
You, sir. Now, sir, Dr. Devashish, sir, your takes are on this part, sir.
Yeah. So first of all, I personally call it IDKH. I don't know headache. Because you see that it is actually very funny that you give a nomenclature which itself is self-expressive, right? So there is a new headache, there is a persistent headache, and the patient remembers from the onset. So these are the characteristics. But how does the patient present to you? The patient presents with a phenotype, and that phenotype can be migraine phenotype or a TTH phenotype or some non-specific phenotype hovering between the two, right? But the real point is this, that it is a reasonably acute onset and the patient remembers from the beginning the onset and it persists within 24 to 48 hours. But if you see that it is also mentioned that you do not have this condition when there is a background migraine, like there is a chronic migraine going on, and then suddenly after some time the patient says, oh, I remember this, so it will not be an NDPH. Similarly, a chronic tension type headache. So you have, that is, those conditions are clearly separate. That's why the NDT came into being. But I think that when I joined neurology 30 years back, and we all know this term called ADEM, acute disseminated encephalomyelitis. I think that's a dustbin diagnosis, because now increasingly you see that something is coming up, and to account for that, what it looks like an ADEM, right? You have got MOG, you have got NMO, you have got MS, you have got lots of other demyelinating disorders which are coming under that rubric. So therefore, the NDPH, in my point of view, is basically a term, a broad rubric which defines this condition about which we don't know anything. Now, the contention that many of these people will have, some of the patients will have a history of viral illness in the background, something in the past, right? There is an entity, as you all know, that there is a, in headache due to infections, right? There is a condition, if it persists for more than 3 months, then it's called a persistent post-infectious headache, right? So then automatically you cannot use the NDPH term. Then it becomes a secondary headache of a specific category. Similarly, all these other associations, as Dr. Ravi Shankar is rightly saying, that these are associations. The somatization disorder. How common somatization disorder is in migraine or in, say, for example, tension type headache? There are a lot of patients, they have a comorbidity of that. So you just cannot pull out those things and say that, oh, now I have got a syndrome because of these things. This is the disease. So I think we should limit ourselves just to the terminology, to the entity, and say that we don't know. We really don't know. And therefore, we should be, ready to identify the phenotypes, the phenotypic variations, as well as the potential triggers and the comorbidities in this. And later on, subsequently, something may come up. Maybe that entire thing is an immunological mechanism, because of an immunological mechanism. How do you know that, right? So we have not really searched for that. So there are a lot of, the diagnosis, once gets refined, a lot of new things coming up, and the diagnosis gets changed, the label gets changed. So I think it's a temporary phase of our understanding that if at all this exists, they exist because of this pattern. And this pattern, what Dr. Ravi Shankar said, and I'm also repeating, that there is a relatively acute onset, the headache is remembered, and the patient has got the persistence of that headache for a long time. That's all. And you did not debate about that, whether this is primary and secondary. It is mandatory in these cases that you rule out all possible secondary causes. Because otherwise, what is the point of being a headache specialist or a good physician? You need to rule out. If a patient is coming to you and saying, a doctor, for last 3-4 months, I just have started this headache and it is continuing, will you not investigate? And if you investigate and find something, then obviously it becomes a secondary headache. It no longer remains an NDPH. Then you have attribute a cause for that. Okay. So therefore, I think this entire debate is actually, losing the semantics. In fact, it is basically what we want to say, that this is a thing which we don't know. It happens in some patients, and then they become, and we know that, even after these two, phenotypes, the patients of NDPH with migrainous phenotypes are better. They respond to treatment slightly better, much better compared to the patients with a TTH kind of a phenotype. I mean, this is my experience. I don't know, Ravi will agree with me or not. But
absolutely, I agree.
So therefore, and also I will tell you that, one of the proponents said, because they respond to certain treatments, and so treatments, we know that all secondary headaches with a particular phenotype response, there are a lot of secondary attacks which responds to the endomethacin, right? So there is nothing new about it, because essentially the pain pathways are the same. And the third thing, which both the speakers have been speaking about, that there is no specific neurobiology that we can understand for this disease, right? Mechanisms, pathophysiological mechanisms. Now, do we know the pathological mechanisms of migraine fully? No. Do we know the mechanisms of TTH? No. Because the basic problem is this, that we do not have a reliable biomarker for this disease. And once we get that, then we'll be able to know much better about this. So therefore, let us keep it as a general term, as a rubric, and then identify the phenotype and treat the phenotype accordingly. And I think you will be rewarded.
Okay, sir. You talked about, sir, phenotypes. Sir, in ICSD 2, they describe the phenotype as a tension type headache. But in ICSD 3, they didn't mention anything of phenotype, just headache, only they describing headache.
Yeah.
But in a literature review, a large case series suggests migrainous picture or migrainous phenotype is more likely than the tension. So what changes happens over ICSD 3 or ICSD 2 between ICSD 3? Initially, it was tension type headache. Characteristic feature was tension type headache.
Because that happens exactly. That is what I'm saying. Because the more you see, the more number of patients you see, gradually your horizon increases. Initially patients, you say that, oh, it looks like a chronic tension type headache. Then a lot of patients come with a migrainous phenotype also, and then say, no, it is possible that, it's similarly like a longitudinally transverse myelitis. Initially, they are all NMOSD, but now we know that there are so many causes of long segment myelitis. So it's a widening of your horizon of vision. The more you see patients and more you are able to investigate more, and you are able to find, and that is that is the basic way to we progress the science. You know, there are two groups. One is called the lumpers and one is called splitters. So science progresses because of splitters, because we need to split and see, and that comes with the technology. And with the technology, we will be able to see much more than this. Probably we might be able to have some idea of the neurobiology of this disease by doing functional MRI or things like that. So therefore, I think a lot to come. But at the moment, it is always safe to say that I don't know. This is the term. This just describes this. But since you have a phenotype like this, so I will treat you like a migraine or a TTH.
Yes, sir. Dr. Ravi, sir.
Yes. Another reason is, your way of thinking is largely influenced by under the person whom you have trained with. Now, the 2004 classification was largely European, and subsequently people like Matthew Robbins and Randy Evans, they wrote a lot of big series of NDPH patients from the United States. So like Debashish said, a larger pool of data was available where migrainous feature subforms were identified. And once you had subforms, then the composition of the third 2018 classification committee was, a lot of Americans were there. So then the American way of thinking came into the picture. And so the Europeans could not, if you go to Europe and Copenhagen, you will find tension type headache is the first headache, commonest type of headache they see in their clinic. But if you go to America, they say chronic migraine. So therefore, it is always across the Atlantic. There are two ways of thinking, and all that pooling made the Europeans to change their way of thinking based on evidence-based data. And that is how you find that it is the controversy has been put to rest, but not including a phenotype in the 2018.
Largely, you know, by the Olison camp, you know, driven by Olison camp, and they were so particular, rigid, and like Bedstein, she says so much of chronic tension type headache. But if you ask, I mean, do you see that chronic tension type headache in your clinics? You don't see that, but they see a lot. They see a lot because they diagnose it as a CTTH. So therefore, there will be a lot of variability the way, as Dr. Ravi Shankar rightly said, the way you are groomed to look into a disease and how do you go? Because these are operational criteria. So it's all open to interpretation. How do you interpret? And how long and how seriously, diligently you take the history. That is very important. Many a times these NDPH patients will be misdiagnosed, at least in our setting, because people see large number of patients in an outpatients, and they might not be, asking about their onset details, right? So they may look like a chronic TTH or a chronic migraine. They might be misdiagnosed.
One question for Dr. Ravi Shankar, sir. You said that you investigate to the fullest. Sir, would you like to say bare minimum investigation or some subdivision for investigation, particular patient? These are the bare minimums like that.
Yes.
So in our setup, we may not go for all investigation at one time. So step by some investigation like that. So would you suggest like that, sir?
Yeah, that's a good question, because straight away you have the list of conditions where they can present with an NDPH like new onset headache, which can be presenting acutely. So keeping that in mind, broadly, first and foremost, you would do imaging. An MRI with contrast, SIH, which may not have the postural linkage, would be in your mind, at the top of your mind. An RCVS like thunderclap headache can also be followed by an acute onset with persistent headache. So you would do an MRI, venous thrombosis, MRV, dissection and RCVS and MRA. This bare minimum you would definitely do in an NDPH. If there is an element of refractoriness, then go invasive and do a CSF with opening pressure in all patients, because both IH and SIH can give rise to an NDPH-like presentation. So in place of migrainous, here I am changing the word not to secondary NDPH, but I'm using NDPH-like. And like Debashish said, once you find the underlying, say GCA, giant cell arteritis, immediately you will change the name from NDPH to giant cell arteritis. So you will do an ESR, you will do a CSF with an opening pressure. And as you go on building up with refractoriness, you'll go on increasing the number of investigations. But in our country, you won't rush off to do a Lyme and things like that. And for those young people who would like to do big research, Sanjay, you are still young. So you're in this category. The easiest thing, Debashish, correct me if I'm wrong and support me if I'm right. If you do an fMRI and PET scan, functional imaging in NDPH cases, which you identify by clinical pattern, and you pick up something in the posterior hypothalamus, you pick up in the rostral brainstem, and you're going to say primary or secondary, that is the best way. As of today, you don't see so many white matter lesions in all the MRIs done for NDPH. So there is something going on there. So if you do an fMRI and PET and you pick up something, then you are going to go in the right direction. So anybody who wants to set up big research, take up your NDPH cases, do this after doing the basics, so ruling out secondary, and you will be hitting something new.
Bimal, one question is for you. Just you defended primary headache. If you know, just more than almost 50% patient have triggers. And your study, it was more than 80%, 90%. So if there is triggers, how would you consider it a primary? Triggers are present in migraine, even in tension type headache. But here it is called as a trigger, a precipitating factor. But here it is just initiated the attack. So if it is initiated the attack, how would you consider it is a primary? Why not secondary? Triggered this headache, triggered by something.
Yes, I aptly showed in my slide, sir, that if the trigger carries its pathophysiology through the course of its headache, then it may be called a secondary headache related to that trigger. But unfortunately, an NDPH never happened. Trigger is for a very small period of time. It incites headache, but headache continues after that. It happens the way it happens in tax, the way it happens in migraine. So I think that we should very closely observe triggers. We should have some research regarding triggers. We have done some in our cases also, but I think that probably triggers are somehow able to incite the mechanism which is causing chronification of headache right from the very beginning. What we should look into is what is the pathophysiology behind chronification of headache right from the very beginning. That is probably the underlying mechanism. And once we know the mechanisms, probably then we'll understand that the way triggers incite mechanisms of migraine, it is a similar way that the triggers incite the mechanisms of NDPH. So it is too early. Like both the experts have agreed to my last two slides. We should not have any haste in saying that is a primary or a secondary headache. Let us wait for some time. Let us have a clear pathophysiology behind it. Let us agree to what it is today. And once we have a clear picture, then I am ready to accept it as a secondary headache or a syndromic headache, but we should have some pathophysiology behind it. That is what my take is.
And Dr. Ravi, one question for you. As a study suggests that it is more common in a pediatric group. Prevalence is more common. Most of the primary headaches are more common in the adult group. But you see the data for chronic daily headache. Large proportion of patients fall in pediatric group having NDPH. So what are the difference? Why it is more prevalent in a pediatric group than adult groups? So I don't think other primary headache are more common in pediatric group than adults. As far as chronic daily headache group is concerned.
Sir, actually, we do not see pediatric patients in our setup usually. We deal with only adult patients. But the reason behind this can be, as I said, that somatization. I did not say the somatization as the cause of the headache, but I said that the somatization tendency, the persistent thoughts about a symptom, may be the behind this presentation. This presentation of remembering the onset and then remembering the persistence of the headache. This may be the behind it.
About 20% of the migraine patients will also have somatization, right? So
yes,
you cannot attribute as a cause. These are all coexistent associations. So you can just say that, okay, fine. I mean, it's not its fault. You are actually, once you say that somatization is responsible for the patient being, remembering the event, that means you are slightly suggesting that his mental condition are such that he remembers the onset and therefore he's so specific about the onset. That is not correct. I think I will not buy that argument, because that would be, in fact, the patient remembers it because probably the patient is more, conscious about the effect of the headache from the beginning, and also that it has become persistent since then. rather than kind of saying that they have some psychiatric illnesses and mental illness and that's why they remember. Like most of the general physicians as well as many of the neurologists feel that migraine is a mental disease, so they say, oh, what do you want to do? You do just lifestyle modification, that's all. It's a mental disease, so what do you and of course the TTH is a different ballgame altogether. So I think that yes, somatization may be an additional comorbidity in this, but to ascribe it as a causative factor will not be correct.
Sir, I totally agree with you. I'm not attributing somatization for the development of this headache. I'm just saying the pathophysiology, because the pathophysiology of somatization is also not known, and any pathophysiology which is behind the somatization, that may be the similar pathophysiology can be behind the NDPH, which is still we do not know.
Okay, now I will ask our both expert panelists to your approach for managing such patients, sir. Dr. Ravi Shankar sir first, you then Dr. Devashish sir. How to manage?
Okay. Now, after the investigations have ruled out any underlying secondary cause for the NDPH presentation, clearly I would go according to the phenotype with which the patient presents. So if there is a migrainous element to the phenotype, then I would start with treatment as for any patient with chronic migraine or as for migraine. And if it is tension type, which are very few in practice, you would start with the usual amitriptyline type of drugs and also rule out comorbidity. But most of them don't settle down with just the pharmacological management. That is where the dilemma comes in. Now, Gone block would be the next choice I would use. And I have tried Botox in a few patients with NDPH also, but to no avail. And the problem comes after Gone block. And I have not used CGRP monoclonal antibodies in any patients with NDPH. And I have also not gone for any neuromodulatory techniques. So I generally get stuck with refractory NDPH. I have not used steroids so far. In fact, I was to ask you to comment on that aspect of it, because I have never found the association of fever to be proven beyond a point where I can most certainly use steroids and see what happens. Methylprednisolone, I have not tried that. So you will have to add to this regime where you would come in with the use of short course of methylprednisolone beyond this when they don't respond.
Sir, would you like to change triggers? Would you like to treat triggers or not? Because we have time.
Yeah, the highlight that's, in fact, I found both the speakers giving so much importance to triggers that it is not at all so easy to identify these triggers listed in the books. The cervicogenic triggering, intubation as a trigger, stress as a trigger, the febrile episode as a trigger. We ask this to all the patients, whether you've had any febrile episode before the onset of your new daily persistent headache, and we don't get an answer. You chase it through CBC, ESR, you chase it in CSF, you don't find the clue anywhere. And now after COVID, what we are seeing is COVID-related headache. May not be called NDPH because there is no remembering the date of onset over there. So NDPH is a different entity from post-COVID headache. So post-COVID headache are post-febrile headaches, post-viral fever, post-infection. As Devashish said, it falls in a different category. So the NDPH pattern is so clearly recognizable. That's why I opened by saying that when you see a zebra, you have to recognize it. You can't then debate whether it's a zebra or not. So NDPH triggering is not as easily visible. It is an association, I said. It is not as visible as mentioned by both the speakers, as mentioned in the books too. So I don't know what is the experience of people like you and Devashish who have seen a lot of patients. So this is my experience, is that triggering, yes, the penny may drop, but then it is not striking you in the face.
Okay. Devashish sir, your approach for such patients, sir.
No, I broadly will agree with what Dr. Ravi Shankar has said. That, and of course, I am skeptical anyway about steroids because in other diseases also. I mean, I'm not so very, unlike many other people who are very fond of steroids. I'm not very person would be reserving it for really cases where they're required. But yes, of course, I think what I do, I can tell you is this, that I actually then would have a sort of a group treatment, right? In a sense that we'll form a group, and in which we'll call the therapists also into action. We'll also have a psychiatrist on board, and we will have I mean, possibly we'll give some neuromodulatory treatment also. I think one of my patient who had gone to outside India, he has got some relief on this continuous this REN device which has come, Nerivio migra, and we have tried the Kefali device in some people, but they always have kind of a suboptimal response. It is not a very good response. Migrainous patients do much better than PTH patients. This is a general observation, but things may vary. And it's a difficult disease to, actually really treat. But then group thing, and also educating, because patients, they come with loads of scans and, all investigations to you. They have already exhausted a lot of avenues. So it is important to discuss with them, spend time with them, and tell them about the disease, about our lack of knowledge and understanding, and then you can take them on board and then give the treatment accordingly. So this is a general plan, but of course I would say that in your, like for example, in your series, the steroids were found to be, and probably you got the triggers of a previous infection, so maybe that might be a subset that needs to be replicated in larger studies. Similarly, I think whether the CGRP antagonists will be of help, that time will tell, because even with the diagnosis of NDPH, some of these patients may have history of migraine long back, like during their childhood or in adolescent age, and then the migraine stopped, and then there was a period of lull for a long time, and then this kind of headache started. So in those patients, probably the CGRPs will be a good choice, maybe a good choice, because there are reports of CGRPs which are also acting on this kind of dual headache diagnosis, where migraine is one component. So therefore, I think this is the general thing, but we have to accept that this is a thing about which we don't know, and the treatment remains empirical.
Okay, sir. In your experience, which one is the best drug for NDPH? Group of drug, or just as a monotherapy or polytherapy?
No, obviously polytherapy. Monotherapy that doesn't work, because these people have already done the usual one. So usually, if you have a migraine phenotype, then what I actually do is that I start the patient on, but the point is this, that they have tried, say, for example, propranolol on about 40 milligram or 80 milligram. So we enhance it to 160 milligram at least in a day. And then we add amitriptyline, and then we also add topiramate if needed. And then maybe that some people may, many of them I have found that at least in my series, often I can say about 25 to 30% will have a lot of myofascial syndromes and pain in other parts of the body, and also there also. So they would benefit from gabapentin, addition of gabapentin. So, it's a cocktail which you need to really work out, and with minimization of side effects. But polytherapy, yes, monotherapy is not going to help.
Okay. So there was, from your side, anything?
No, so as a non-headache expert, what I understand that what everybody has told, that it is obviously pathophysiology has not been well understood, and it is still an evolving entity. But as a neurologist, what I now understand, that we have to recognize this pattern of a new daily persistent headache, and once you rule out the secondary causes, it by itself becomes probably a disease or syndrome, and which have a different phenotype, and we have to manage accordingly. So that is what I understood from the whole of the debate. Whether to break it into a primary or secondary, still the jury is out. But understand that once you ruled out all the secondary causes and everything, and then there is a definite diagnostic criteria. So why not to take into as a primary headache disorder? That will be my thought process at the end of it. One question is that to all the experts, are there any long-term study? Let us say what happens to this patient after 5 years or 10 years? Because whatever treatment we are discussing is, let us say, if they are not responding, these patients usually come to us maybe within 6 months or 1 year, and then they do not respond. So what happens to these patients in the long term, 5, 10 years? Are there any studies or data available, or is there any, sir, Ravi Shankar sir has seen so many patients, so what will be long-term outcome of these patients?
Yeah, there are studies. The biggest one of them is from Sanjay and Devashish, correct me if I'm wrong, is from Randy Evans and Ted Seifert. They have got about 350 cases, and they have put it into 3 patterns. One is spontaneous remitting, another is persistent, and the third is relapsing remitting. Now, in my experience, uniformly, as long as the patient has followed up with me, I don't know if they have gone somewhere else, it has always been persistent and difficult to treat. I have not seen a single patient going into remission with a label of NDPH. Then I would have been victorious, and I would have been so thankful to God that I have got an answer to my NDPH patients, because this is the group which is most refractory in practice. So the relapsing remitting and the remitting ones, I have not seen any. Most of my patients have been difficult and persistent as long as they have come with me, and they've been following up for, say, 3 to 5 years that I remember. But they have got a big series from the US, which has got 3 types. So comments from the others.
So there is a spontaneous remission, no remission by treatment, you can say.
Yes.
Sir, can I come in here? Sanjay,
Yeah.
sir.
Yeah.
I don't want to pose as an expert, but since me and Ravi have been working on this headache for last few years, I have certain observations regarding NDPH, so I want to share them.
Yeah.
And there were some questions also from Dr. Sanjay sir, which I want to address here. One was the thing of somatization. Like somatization is like plowing a field, putting manure or fertilizers into a field, and once it is prepared, it can grow any crop. So somatization is like that only. Once the brain is prepared for chronicity, it can grow chronic headache, any type, chronic tension headache, chronic migraine, and NDPH also. The issue is the chronic from the onset, which we are not very sure about. So to answer Chaturbhuj sir, that whether we have a long-term study, no, we are very young to do a very prospective, to say that we prospectively observed large number of series. But in our paper, we actually retrospectively reviewed these patients. And that was the reason that we found large number of people with somatization. Now the issue was when we went back into the history, we found that large number of people had many symptoms in the past, which persisted for months together. And many of those symptoms, they could actually really remember the onset, not the dates, but they clearly remembered the circumstances in which that symptoms started. Many of them had headaches previously. Many of them had lower back pains, other kind of pains, the bladder symptoms. And they were severe enough for them to take consultations for them. And NDPH was actually the 3rd, 4th, or 5th symptom. So that is how we came to the conclusion that actually it is the plowing of the field which the somatization does. And we are not saying that this is the cause of NDPH. We are saying that the somatization probably is a cause for chronification, and which is well known, till date also, because one of the reasons of chronic migraine into going into chronification from episodic is either increase in frequency of headache, medication overuse, and psychiatric comorbidity. So this was and the third question which Dr. Sanjay asked from Ravi was, why so much of representation in childhood? I think I'll have to take support of Dr. Chaturbhuj here. It is, again, the pathophysiological mechanisms of chronification which have come from radiological studies are such that there is a loss of interneuron inhibition, which results into excessive stimulation of the brain, which has been supposed to be a reason behind chronification. The same mechanism which probably in childhood occurs in patients with CP for refractoriness of seizure and presentation of syndromes, epilepsy syndromes in childhood. correct me, Chaturvedi sir, if I'm wrong, because probably the surrounding inhibition or the inhibition in the childhood brain is probably not that robust as it is in adults. Probably that could be one of the reason of overrepresentation of NDPH in children.
Okay. There is one question from the audience. What is the characteristic of a headache in vasculitis? So, Ravi Shankar sir, your opinion for this question.
There is
Characteristic of
no,
headache in vasculitis.
yeah, there is no phenotype which is characteristic for vasculitis, and the headache pattern will not give the clue. It is only by investigation that you will be able to establish the headache of this thing. And unless, I hope they are not asking about giant cell arteritis, which is clearly different.
Okay. Shatruz, anything else?
So, because now role of steroid, I think Sanjay has done he has published that series of role of steroid in NDPH and trying methylprednisolone and this. I have seen him trying in many patients, and some of the patient because I was a silent observer of those treatments. So what I have seen is some of them do dramatically respond. I also tried in some of the patient probably with NDPH. So a small proportion do responded, but many patients did not respond also. But in Sanjay's case, many patients, I saw myself observing that those were patients who were coming with almost trying all the other therapies and giving a short course of methylprednisolone for 3 days. Dramatically improved the headache in those patients. Obviously, I don't have any long-term effect of that, but some of the patients.
Actually, we had planned with you, but we could not succeed in that study.
We thought of planning a randomized control trial also, but various reasons I think could not do it.
Yeah, unless you have a placebo arm and you have to do a randomized trial.
Yes, sir. We had planned but could not do.
Yeah.
No, so sir, those patients were like because they have been tried on everything and they came as a refractory to a headache specialist.
Many patients who come to Dr. Ravi Shankar also tried many things and they get better because of Dr. Ravi Shankar's approach. So,
because I send them to Debashish.
So the physician matters, the circumstances matter. There's a patient physician who listens, who thinks that the headaches are real, they are disabling, but I would just add one thing from Dr. Ravi Shankar, though they are difficult to treat, and though they, you have hardly you see remissions in practice, but you can do a improve quality of life for them, and they become better at least from what they are if you judiciously use the medication. So it's not a lost case. So you try out.
Have you seen spontaneous remission, Debashish?
I have seen only 1 or 2 patients, very rare, very rare.
Actually,
any of you have seen? Sanjay,
they did come back
Vimal.
to us. They didn't come back if there is a spontaneous remission unless until you do prospective study.
I have seen about a couple of patients, but very rare. I mean, out of about 150 to 200 patients, I think very less.
Sir, the point I was making is that it may be worth trying a short course of steroid. We don't know the duration and doses, but it may be worth trying in some of the refractory cases.
Even in chronic migraine, IMOS, some study have demonstrated, so we can try. But definitely there are some. Actually,
see that the point is that if you take that position that okay, fine, we have tried everything, there is nothing else to be done, and now steroids are available with us, let us try steroids. So that is one way of looking at it, and that actually happened in COVID. You see that we have nothing else, so we start chloroquine, starting from chloroquine to all that thing. What harm does it make? And kind of that kind of a logic. But I would say that until and unless you have a evidence base, I would be very hesitant to start.
Okay.
So, sir, you are in a very good position now as a president of the Indian Academy and as one of the leading headache experts. Why don't all of you, I think Vimal, Ravi Shankar sir, everybody will agree, you plan a randomized control trial. This will be a path breaking.
Yeah, we can definitely. Sanjay should take the lead. Sanjay, I have to leave now. Somebody has come to meet me.
Okay, sir.
Okay, thank you.
Thank you, sir. Thank you, sir, for being here. Just in last, should we go for poll again?
So we'll have a last poll. Let us see if anything changes. Support team, we can have the poll.
Yes, sir.
please.
Just allow me 1 second because system takes time, sir.
No problem.
So I will request everyone to just give your opinion. Same question again.
Okay, I think we can have the results.
Oh,
So
now it is reversed.
it has changed after the poll discussion. I think
Now Dr. Bimal and Dr. Ravi Shankar sir has convinced people that it
I
is
think
not
the,
like
the
a primary.
poll is like
So-
NDPH only.
It is reversed now. So
but
it is,
it has, I think it made a difference. And at least as a non-headache, I can say there is a, at least now I am more clear, although you cannot say you are all fully clear, but I am more clear about the condition and how to investigate and how to treat it. So I think that is itself is, I think, a good message we can give to the
Goal,
audience.
yeah. Chaturbuj, you summarized it nicely, and why this poll change is important because it is in keeping with the way the International Classification of Headache Disorders has, as of today, in 2018, put it in the primary category. So NDPH, through the international experts, is still primary. So the debate is good for making it interesting.
yes, sir. And thank you, sir, for being here. You just made us very. And Vimal and Ravi,
You
thank
made
you.
it interesting. Both of you,
Uh,
you made it interesting, and we look forward to more work from you all in this area. And as Chaturbuj said, that this is a fertile area for research, and there's one area of headache where we still don't know so much.
Yes,
And
sir.
Sanjay is there to guide you if you all need any help on this topic. He's written extensively, so I think it's a wonderful debate, which I think has woken up a lot of thoughts on this entity. Thank you, Chaturbuj.
Thank you, sir. Thank you, sir.
Thank you, everyone.
Thank
I
you,
will
sir.
invite
Thank you, sir.
Mr.
Thank you, Vimal. Thank you.
I think let us do the I will invite Mr. D'Souza, who is providing us all the logistic support and all the sending all the invitation. So to he has they have been responsible for spreading the message. So I will invite Mr. D'Souza to propose a vote of thanks to all our esteemed delegates and participants.
Thank you very much, Dr. Chaturbuj. Good evening, doctors. I would like to thank the speakers, both Dr. Paliwal and Dr. Unial, who debated at length on the topic, new daily persistent headaches. Is it a disease or is it a syndrome? A special word of thanks goes to expert panelists, Dr. K. Ravi Shankar, as well as Dr. Debashish, whose wealth of experience and expert comments has truly made this program an enriching one. My thanks to Dr. Sanjay Prakash, who moderated the session very well by summarizing the key aspects on this topic. Last but not least, I would like to thank Dr. Chaturbuj, who has been the brainchild of this entire webinar series and also gives his valuable input on key take-home messages that is very beneficial for the clinician practice. My personal thanks to the more than 150 participants who took time to make this program a meaningful one, and looking forward to seeing all of you on every second Friday of the month, and the next one being on the 11th of August. Thank you very much, and good night to all of you. Thank you.
Thank you.
Thank you. Thank you,
Michael.
Ravi sir, Vimal and Ravi, everyone. Thank you very much. It was a
Thank you,
pleasure
sir.
listening
Thank
to
you,
all
Vimal.
of you.
Thank
Thank
you,
you very
Ravi.
much. Thank
Thank
you.
you, sir.
Thank you, sir.
Thank you. Bye, sir.
Thank you, sir.
Bye.
Thank you. Thank you.
Thank you, Daruj. Bye, sir.
Thank you, sir.